Thank you, Sue. Hi, everyone. Thank you for being here today and taking the time out. Yeah, I was giving the title Shoulder the Pain, which is a bit of a pun. It's a good title, so we'll work with that. And let me start the slideshow.
Looks good.
All right. Good.
Yes. Just you can do from up. There it is. Excellent. Thank you.
You're welcome. All right. Yeah. So yeah, this is me. Just like Sue said, Umer Dasti. I'm an orthopedic surgeon. I did most of my training here in New Jersey, except 1 year in Boston at the end. I joined Ridgewood Orthopedic Group about almost 9 years ago. This summer will be 9 years, and I've been at Ridgewood Ortho and the Valley Hospital since then. It's been a wonderful time. My area of expertise is really shoulder surgery. I did a sports medicine fellowship, and over the last few years, I've kind of narrowed my practice down to where my focus is mainly on shoulder issues. I do shoulder arthroscopy, meaning go into the camera, do surgery through the camera. I do shoulder replacements and shoulder fractures, injuries to the shoulder. So we'll kind of talk a little bit about some of those things in the next few minutes. So I thought I'll start with kind of just an overview of the shoulder, talk a little bit about the anatomy of the shoulder, what our shoulder does. So we're all kind of coming from the same place before we go on and kind of address three of the most common causes of shoulder pain. And then we'll have some time for questions at the end. So one question I get sometimes, there's some confusion actually, there's no shoulder bone. So the shoulder is an area of the body, really. It's not a specific bone. There's no hip bone. There's no knee bone. There's no shoulder bone. These are areas of the body. These are joints. These are where two or three bones meet and form a joint. So in the case of the shoulder, we see here kind of a picture. The shoulder refers to the area where the humerus, the upper arm bone, this long bone here, meets the shoulder blade and the clavicle. So where those three come together, we kind of call that area the shoulder. So again, it includes the humerus, the upper arm bone, the scapula, the shoulder blade, and the clavicle or the collarbone. And so the shoulder, it's a ball and socket joint. You can see in this area, if you can see my cursor, at the top of the humerus is a ball or a hemisphere, half a ball, and it's got a smooth cartilage on it. And the socket of the shoulder joint is actually on the shoulder blade, and we call that the glenoid. So the medical term for that socket is the glenoid. So we have the humeral head and the glenoid, and that's the main ball and socket shoulder joint. So it kind of gives us our full kind of 360 shoulder motion. We have a small joint up here where the collarbone meets the shoulder blade. We call that the acromioclavicular joint or the AC joint. And it's a small joint. It's usually not a problem. You can have an injury involving that joint. We call that a shoulder separation. We may or may not have time to talk about those type of injuries, but they're common in sports and football players, bike accidents, things like that. But that's a kind of overview of the bony anatomy of the shoulder. And then moving on, if we start layering on top of it a little bit, we see here kind of the first layer of muscles on the shoulder. The big muscle over the top is the deltoid, this big shoulder muscle. It's kind of like a shoulder pad that sits over the top. That's your deltoid muscle. Here we see the biceps, the pectoralis major muscle. If we were to peel those back and look a little deeper, this picture here on the right shows what you would see at that point. And then that's where we start looking at the rotator cuff. Everyone knows a lot, or everyone's heard about the rotator cuff, and we'll have a little bit to talk about injuries to the rotator cuff and the biceps tendon. So down here at the bottom, this is the top of the biceps muscle, and the biceps has two tendons at the top of it. That's why it's called biceps, because of the two. And we have this long head, this long kind of thin tendon here, and then we call this the short head. And the long head of the biceps can be a problem in some cases. These muscles around it here are the rotator cuff. So I think we'll talk about that here on this slide. So the rotator cuff, I've heard people say rotator cuff, and it's rotator cuff, the like C-U-F-F, like the cuff of a shirt. And the rotator cuff are a group of 4 muscles, the supraspinatus, infraspinatus, subscapularis, and teres minor. These 4 muscles attach at the top of the arm bone, and they're responsible for a lot of the motion, bring the arm up and out and in. And so these are really critical. So the rotator cuff, they're muscles, and then they become tendons, where the tendons attach to the bone. Where those muscles attach to the bone, that's the tendon area, the white area. And usually when people have a problem with the rotator cuff, it's in that tendinous area where the tendon attaches to the bone. Tears of the rotator cuff, we'll talk about it, usually involve the tendon separating a little bit from the bone. Rarely people have injuries of the muscles of the rotator cuff. So usually this is a tendon injury of the rotator cuff. And this is again just showing the biceps. We talked again a little about that. That runs right through the middle of the shoulder. And then lastly, just looking at that socket, one last structure that's important to understand with regards to that shoulder is if you were to look at that socket on the shoulder blade en face, like if you were to remove the upper arm bone and then turn and look at it straight on, you'd see the socket, and all around the rim of the socket is a big, thick cartilage called the labrum, and it helps the ball stay centered within the socket, and that can be a problem area in some cases. So that's a little bit about kind of the anatomy, and so now maybe we'll get into some of these main players, these main causes of shoulder pain. The first thing here is bursitis or tendonitis. These in some ways are very similar. They present very similar. I have a little picture here. We'll talk about it. But the bursa is a small space or a sac that sits between the top of the rotator cuff and the underside of that shoulder blade. And it helps cushion the rotator cuff and cushion the top of the arm when the arm comes up. It gives you a little padding between this bone and this rotator cuff, this blue bursa. And so bursitis is inflammation of that bursa, and tendonitis is when you have inflammation of that rotator cuff tendon right out here, right at the end of that tendon where it attaches to the bone. You can have tendonitis. And both of them are usually due to what we call impingement, meaning the arm comes up and the rotator cuff gets pinched underneath the shoulder blade, and repetitive impingement or overuse can lead to bursitis or tendonitis. People usually come in saying they have pain here or even in the upper arm, pain at night, pain when they get into that impingement position when they reach up. And you can kind of have a little model here to kind of, I don't know if you can see that, but this is the arm, this is the rotator cuff, the top of the shoulder blade. So you can kind of see how the rotator cuff can pinch, and that can lead to bursitis and tendonitis. Diagnosis can be made often by talking to the patient, examining them. An MRI can be obtained to help confirm the diagnosis. You can see the bursitis or tendonitis on the MRI in many cases. These are usually short-lived conditions. Bursitis and tendonitis can heal. These can be healed or cured or can go away. They are not usually big permanent problems. We'll talk later about things like arthritis or tears. These are things that can't heal and can't easily be fixed. Bursitis and tendonitis can be cured or helped or fixed with anti-inflammatories. We'll usually start with simple over-the-counter things like Advil, Aleve, sometimes prescription versions of those things, which are a little bit stronger. If those things don't work, we'll start talking about cortisone injections. Usually what we do in this case is a cortisone injection. Cortisone is a very strong anti-inflammatory, and we'll do an injection in the office, and that can often help. And physical therapy, there's definitely a role for physical therapy, sometimes correcting some of the mechanics, why, what was leading to the impingement, the repetitive impingement. Is it something in the posture that's leading to that rotator cuff impinging and led to the bursitis? What's the root cause? Something in the posture, something in the mechanics. Physical therapy can help in those regards. Up next, we have rotator cuff tears. Many people have heard about this. When people come into the office, many people are worried they have a rotator cuff tear, and and that's not unreasonable. They are a problem, but many of them are not big bad tears. They're not. Many of them are small partial tears. These can be treated without surgery. So like I said, I think in the beginning when we were talking about anatomy, usually when we're talking about an injury of the rotator cuff or a tear of the rotator cuff, we're talking about an injury to the tendon part of the muscle. And we can see here a little diagram. You see the muscle here, then it becomes tendon, and you can see this kind of ugly looking tear here where it's attaching to the bone. And when we talk about rotator cuff tears, like I said, there are 4 rotator cuff muscles and tendons. So you could say someone has a tear of 1 of them or 2 of them, or if they're really unlucky, 3 or 4 of them. And then we also talk about them being partial or full. I think I have a little diagram to kind of explain the difference. Obviously, a partial tear, not as bad as a full tear. And then the other way we can discuss them and divide them is traumatic or degenerative. Traumatic refers to kind of the tendon was cruising along perfectly well, and then someone had an injury like a fall, or the arm gets yanked or something happens, a car accident, and they have the tendon tear. That's a traumatic tear. And then we have what we call degenerative tears. These are kind of wear and tear, repetitive overuse. Slowly the tendon wears down, thins out, kind of like getting a hole in your jeans, or a fray. You can think of it as a fraying rope. Slowly the tendon wears and wears until it becomes a full tear. This is a picture kind of looking at what we would see if we went in for arthroscopic surgery, if we put a camera in the shoulder. This is the top of the arm bone. That little in there, you can kind of see peeking through that is the cartilage on the ball of the joint, and then this is the tendon up here. This white, thick white structure is the tendon, and it is separated from this area here. So this gap from here to here, oops, this gap should not be there. This tendon should be down here attached to this bone. People usually come in, again, similar to the bursitis tendonitis, pain at the top of the shoulder, pain when they move the arm. Depends which tendon is involved. If it's the supraspinatus or infraspinatus on the top, pain when they come in, subscapularis on the inside, pain when they kind of rotate inward, and teres minor, pain rotating outward. So it depends which tendon, but pain usually moving the arm. Sometimes if it's a very big tear, large tears, bad tears, people lose the, really have a very restricted motion. They just can't lift the arm. You ask them, can you lift your arm? And they say, I can't, I just can't lift it. I don't have the power. It feels very weak. Usually that implies kind of a larger tear, 2 or 3 tendons. Most people can compensate fairly well with a 1 tendon tear and actually still be able to lift the arm, even though the tendon is torn. Some of the other muscles around the area can help it. They have pain, but they're able to still move it at least. So talking a little bit about diagnosing them, again, examination, talking to the patient, getting the history, looking at how they're moving. And then, of course, again, an MRI. X-rays, we'll usually start with an X-ray in the office for all these things. If someone comes in with shoulder pain, the first step is usually an X-ray. And some people ask why. Most of this stuff shows up better on an MRI. You do sometimes see things on an X-ray. You see bone spurs. We'll talk about arthritis after this. Arthritis shows up fairly well on an X-ray. And so there's some utility to starting with an X-ray. But ultimately, many times we do end up eventually going to the next step with an MRI. Treatment for rotator cuff tears is very variable because tears are very, very variable and patients are very variable. So it really depends on how big the tear is, how bad it is, where it is. And it really, really depends on who the patient is, what are their expectations, what do they like to do, What do they need to be able to do? This guy here definitely needs all four of his rotator cuff tendons to be in peak form. So treatment could be something if it's maybe a very small tear, strain, just rest, let it heal, give it some time. Activity modification, meaning avoid doing what this guy is doing, avoid aggravating factors, and some physical therapy again to try to strengthen the other muscles around there. You take a little bit of stress off that tendon that's torn, strengthen some of the other muscles around it, and it gives it a chance to heal and recover. Analgesics, meaning things for pain, Tylenol, Advil, Aleve, sometimes in the early stages. And then, of course, sometimes some of these do need surgery. This is kind of, we talked a little bit about partial or full tear. So this is kind of an example of what I mean by a partial tear. If you see this picture here on the left, the one that says A, you can see the tendon is still attached here. It's separated here. In this area here, it is separated, but it is still attached in this area here. Then if we look to the right, B, we now see that the tendon has completely detached from this area, and it's even pulled back a little bit. We call this retraction. Once we start to see a tendon that's fully torn and retracted, we start worrying about timing of surgery. Then there's a little bit of a clock ticking with regards to trying to, if someone wanted to have that fixed, trying to fix that. Retracted tears, if they're left for many years, become a problem. Yeah, and talking about treatment, partial tears, these can heal. Surgery should really be a last resort for a partial tear. Try everything possible to avoid surgery for a partial tear. Give people a lot of time, see if they can heal, see if the pain can go away. Physical therapy, give them some time. The full tears, a little bit the opposite. Usually if someone comes in and we get an MRI and I see a full thickness tear of the rotator cuff, in a lot of those cases, we will talk about surgery. It is age dependent. They can be difficult to fix at a certain point. They need a good blood supply. They need really healthy blood supply to be able to heal. And so the only issue there is that we know results of rotator cuff surgery, people over 75, late 70s, start to get a little less predictable, meaning sometimes you can do the surgery and things can come out very well, but they still have pain or they don't heal well, and maybe the surgery doesn't help as much. So we take that into consideration, but age is just a number, and so we take all factors into consideration when we talk about surgery or not surgery. This is a MRI example. Some people are always curious about what do the MRIs show us. And so, the MRI slice the shoulder front, side, back, this way. And so this is a slice front to back, and we can see here the humerus bone, and here's the muscle of the rotator cuff. Here where it starts to get dark gray or black is the tendon. And now it's attaching here nicely to the bone. We can see it attaching. This picture on the right, muscle, tendon, and then we see a big gap here. This white is a big gap. So the end of the tendon is sitting here. It should be here. This is a full tear of the rotator cuff tendon. So talking about surgery, I'm sure a lot of you are here to, this is kind of the juicy part or the interesting part. What we do in surgery for some of these things. So traditionally, rotator cuff tears were fixed in an open fashion, meaning an incision over the top of the shoulder. They had to detach the big deltoid muscle to get down to the rotator cuff. Now the kind of the trend is to do arthroscopic surgery. So this is a picture of arthroscopic surgery on the right. We can do this through 4 small incisions on around the shoulder, 1 for the camera and 3 for the instruments, and we can get everything kind of fixed up like that. It's a little smaller incisions, less pain, faster recovery. Again, this is a picture, we kind of showed the picture before of the rotator cuff. This is another picture here showing the bone where it should attach. This is the tendon. the repair has started. So little suture anchors have been placed in the bone, and tendon and sutures pass through the tendon to kind of repair the tendon down to the bone. I think I have a little video here, if this will play. So I'll skip through this, it's a little long, but again, this is the muscle tendon. This gap here is the tear. So this gap should not be there. This edge of the tendon has separated from the tendon here. This is the camera coming in here, and then these other three things are what we call cannulas. They're little portals. And so this is showing that the tear should be there. The tendon should be there where that pulled it back. This is what we call a burr. So we go in and clean up the footprint, clean up kind of the stump that was left over after the tear, the little bit that was left on the bone. We clean all that up and clean up the bone and get it ready. And now this is showing preparation for placement of what we call suture anchors. These are little, nowadays, these are plastic or suture, and they go into the bone. They look like drywall anchors. If anyone's ever used drywall anchors to hang things up, they actually look a little bit like drywall anchors, and they have sutures on them. And we pass these sutures, kind of weave them in and out of the tendon, and then kind of fix the tendon back down to the bone. So this is just one example of one way to do it. It's very dependent when you get in. It's a bit of an art. You look at the tear, the shape of the tear, how big, how many tendons. You decide where to place those anchors, where to place those stitches. And ultimately, the idea is to tack that tendon back down to the bone. So you're reattaching the tendon to the bone. And then that tendon and bone, they have to heal. And that takes about 12 weeks. We know from scientific study that that process takes about 12 weeks. So it's not like these tendons are not like these sutures are there to hold the tendon forever. They're there to bring the tendon and bone back together so that the body can heal them. It's kind of like putting stitches in the skin. If you were to have a cut in the skin, you put stitches, the skin's got to heal. And likewise, this tendon and bone have to heal. So everything's not done as soon as you come out of the OR. There's still a lot of healing to be done, and then a lot of physical therapy and recovery. That's a little animation of the, so recovery, rotator cuff surgery, usually sling for 6 weeks. That's really the part everyone hates. The sling can come off for showering, for getting changed, getting dressed, for doing your physical therapy. But otherwise, pretty much you're in that sling for 24 hours a day for about 6 weeks. And you start physical therapy almost, about a week, 10 days after surgery. And physical therapy goes for about 3 to 4 months. And really the full recovery can be about 6 months for this type of surgery. So it's a long surgery. Results are quite good. I think I have some slides here, just kind of what's the state of the art, what are the newest things in rotator cuff surgery. One thing here, I put a picture, kind of the evolution of those suture anchors that we use. The video showed the use of these kind of plastic anchors. When everything started, they were metal anchors. Then we moved to plastic, and lately the trend is these all suture anchors, very, very low profile. You can get these in through very tiny little drill holes. And so that's been a nice evolution. And then the other very kind of hot area is use of augmentation or biologic augmentation. So to try to get these to heal, we now have several kind of augment or graft augments that we can use. So we do the surgery, repair the tendon, and then we can lay these grafts on top to kind of stimulate healing. These are collagen grafts. Some of them are human cadaver. Some of them are synthetic. These are grafts that help kind of augment and aid in the healing of that tendon. All right, moving on to shoulder arthritis. We'll move out of the rotator cuff world into shoulder arthritis. Arthritis in general refers to a degenerative process of the smooth cartilage on the ends of any joint. Anywhere two bones meet, the ends of the bone will have a kind of thick layer of cartilage, and we call that the articular cartilage. And arthritis refers to kind of a disease or wear of that cartilage. The most common form is osteoarthritis. There's rheumatoid arthritis, post-traumatic arthritis, various other forms of arthritis. The most common form, what we commonly refer to as arthritis, is osteoarthritis. Osteoarthritis is a combination of genetics, wear and tear. It's usually seen in a more in an elderly population versus something like rheumatoid arthritis, which is a disease that can start to affect people in their 30s, 40s. So usually we're talking about osteoarthritis, and in particular in the shoulder, it's there, we see it. I see people all day long with shoulder arthritis, but it's just way less common. Everyone at this point, almost everyone knows someone that's had a hip or a knee replacement. Hip and knee arthritis are much more common than shoulder arthritis, and in some ways more debilitating. I think the shoulder arthritis is often better tolerated than hip or knee arthritis because we don't walk on our hands. We don't bear weight through our shoulders. And so I think the shoulder sees a lot less wear and tear than our hips and knees. And if someone has a bad shoulder, sometimes they can tolerate it better than their bad hip or their bad knee. That being said, sometimes people do, it does get to the point where it needs to have something done. And so we'll talk a little bit about some of those options. This is a X-ray demonstration, like I had said earlier. Arthritis can be seen on an X-ray. The X-ray on the left is a normal shoulder. We see a nice round spherical or hemispherical humeral head, and then some space here between the ball and the socket. On the right, you see the picture of arthritis. So the head has gone a little bit out of round. It's not so well-rounded anymore. It's a little uneven. And most importantly, you see here, there is no space between the ball and the socket, the ball and the glenoid anymore. This is, you would say, bone-on-bone shoulder arthritis. Again, usually pain upper arm. Commonly, you see a stiffness or a loss of motion. It's a little bit different than the rotator cuff tear person who you say, can you lift your arm? And they say, no, it's so weak, I just can't lift it. And then the doctor or the examiner can come in and you are able to lift that arm. There's nothing wrong. There's nothing stopping it. It's just the person's tendon that lifts the arm is torn. And so they can't lift it under their own power, but the arm will still go up. With arthritis, because of all of that kind of wear and tear and the bone on bone and the pain and the stiffness and the inflammation, what you see is the loss of motion, and even the examiner cannot bring it up over the head. That's true, kind of a true stiffness versus just a weakness. Treatment, similar to some of the other things, physical therapy, anti-inflammatories. We do cortisone injections for shoulder arthritis. I showed that kind of picture of the shoulder injection for bursitis. Shoulder injection for arthritis has got to go a little bit deeper. You really want to get that in that space between the humeral head and the glenoid. And so accessing that space is a little trickier. I prefer that be done under X-ray or ultrasound guidance. So we'll usually set that up as a smaller mini procedure, in contrast to a shoulder bursitis injection, which is very easy to do, what we call kind of blind without an ultrasound, or a knee injection. Knee injections are very easy to do blind without an ultrasound. And then surgery, last resort, again, as always, is surgery, but sometimes it does come to that. So in talking about surgery for shoulder arthritis, what we're talking about is a shoulder replacement, a total shoulder replacement, or what we call a total shoulder arthroplasty, which is the medical term for joint replacement. And there are two flavors of shoulder replacement. The traditional, what you could call a regular or an anatomic shoulder replacement, is this example on the left. It makes sense. You put a ball where the ball was, you put a socket where the socket was, and this is a regular shoulder replacement. There's another design. This is called a reverse shoulder replacement, or reverse total shoulder arthroplasty. And that is demonstrated on the right. It's called a reverse because we're reversing the orientation of the ball in the socket. we're putting a ball where the socket was, and a socket, this is a little cup, a socket where the ball was. And this is done for various reasons. Most commonly, if someone has shoulder arthritis and on top of it, they have a bad rotator cuff or a rotator cuff tear, then the reverse shoulder replacement is the better option. It's a bit of a complicated biomechanical trick, but suffice it to say, this came out in America, I think 10, 12 years ago. It was in Europe earlier. Prior to that, if you did a shoulder replacement in someone with bad arthritis, but on top of it, they had a big bad rotator cuff tear that could not be fixed, they had no option, the results were not great. You were helping some of their arthritis pain, but not doing anything for the rotator cuff tear part of the equation. And the reverse shoulder replacement addresses both of those issues at the same time. Either way, from the patient's perspective, they probably would not know. It's the same incision, both take about the same amount of time. Rehab protocol is the same. So in the end, really, it's from the patient's perspective, they end up kind of being very similar. This is a little animation. We had the animation of the rotator cuff repair. This is a little animation, checking my time, little animation of kind of the shoulder replacement. This is a regular anatomic shoulder replacement. So we're going to see getting into the joint here. See the worn out ball and socket, preparation of the socket, and then a plastic glenoid or socket goes in, three or four little pegs. Then this is the stem on the humer side, and then the metal ball. So that is a regular shoulder replacement. And this is a quick little animation of a reverse shoulder replacement. So again, we have the ball and the socket. Showing the rotator cuff tear. And so we see the preparation of the glenoid here. In contrast to the regular shoulder replacement, in this case, usually some screws are used to hold this component into place. Again, like the regular shoulder replacement, a stem is placed in the humerus, and that is the cup or socket going on the humerus. And that is the completed reverse shoulder replacement. Believe it or not, these can be performed in the same day setting. I think about half of my patients probably go home the same day and half choose to stay overnight. It's really a discussion I have with the patient about what their preference is. Some people feel more comfortable being in the hospital overnight, but in many cases, there really is not much to be gained from the overnight stay. You're in a sling for 4 weeks either way. We do it with a nerve block. So patients get a nerve block for surgery. Arm and shoulder are usually numb for 24 to 36 hours. And so it's not like you need pain medicine overnight. So many people choose to go home the same day as the surgery. Sling for 4 weeks, 3 to 4 months of physical therapy usually, and 4 to 6 months for full recovery. We talked a little bit before about kind of state of the art for the rotator cuff, and just thinking about kind of where some new things are with regards to shoulder replacement. This is one. We have now what we call stemless shoulder replacement. So those videos and most of the other pictures I showed that kind of metal stem going down the bone canal of the humerus bone, and then the head sitting on that stem. We have these stemless implants, so that they're small, usually flanged implants, and so they avoid the need to kind of violate and go down the humeral canal and into the bone marrow, so a little less bleeding, a little less pain. So this is called a stemless shoulder replacement. Oh, robots. No robotic shoulder replacement as of right now. I think it is on the horizon. Many of you may know that we have robotic hip and knee replacement. Although rest assured, your surgeon is still there. This is the actual, one of the most commonly used robots is the Mako. This is the one Valley Hospital has, made by Stryker. So the Mako, and it's like this: the surgeon's hand is on the instruments. This is the robotic arm. The surgeon's hand is on the instruments. He's still guiding it. The robot has a preloaded template and CAT scan of the patient's knee, and so it's a combination of the surgeon and the robot is doing the surgery. It's not the surgeon sitting back and drinking a coffee while the robot runs through the surgery. But I think this is coming soon for the shoulder, maybe within a year or two. And once it does, we'll be ready at Valley to kind of start doing these. We do a CAT scan pre-op for the shoulder replacements, and we do make a 3D model. This is an example in the bottom left. So every patient that has a shoulder replacement gets a CAT scan. 3D model is created in the software, and we have the software. And so prior to the surgery, you can manipulate in kind of 3 dimensions their actual anatomy. You can basically do the surgery virtually before you go do the real surgery, and it helps with planning replacement of implants, sizing of implants. You kind of know ahead of time what size you're going to use. All of these parts, all of those prostheses that we saw in those pictures and videos, they come in many sizes to fit any anatomy, any patient, short, tall, big, small. And so we can sometimes be better prepared. We know what we're going to put in, what sizes, what fits that patient best. In some cases, if necessary, these are examples of 3D printed custom implants or custom guides. If it's a very tricky case, and I think it's going to be very hard to get something in the perfect place where I want it, you can have these 3D printed guides created to help be a little bit more precise in placement of implants. And I think that is it. We kind of got through those 3 big players.
Yeah.
If anyone has questions.
Thank you.
I didn't open the chat.
Yeah, just somebody had a question. Thank you so much. That was really interesting, and many can relate. Somebody is asking, does bursitis the pain, does it kind of extend to the upper arm and chest? Is it related to that?
Definitely upper arm. I have a lot of patients with any shoulder condition, arthritis. I don't know if you can see. A lot of people come in with pain here, and ultimately it's a shoulder problem. It's a rotator cuff tear or arthritis, but the pain is here, and people say, well, but it can't be my shoulder. It's right here. It's my arm. It's my biceps. What do you mean it's my shoulder? That's not right. For whatever reason, it's the way we're wired, where we get pain. The problem's here, but we feel it here. Very common. Chest, not so. Bursitis for sure. Bursitis, upper arm pain, bursitis for sure. Chest, not so much. You can get a little bit. A lot of people, I didn't talk about that, but a lot of people with shoulder problems get neck problems. A lot of people with neck problems get shoulder problems because they're kind of the shoulder bone's connected to the neck. So chest, not so much. You can see a little bit into here, maybe, if that's what you mean by chest. Down here, no. That one you need our cardiology fellows for.
Gotta be careful of all that. Somebody asked, what is a frozen shoulder?
Oh, yeah. Yeah, we didn't have time to talk about that. So medical term for frozen shoulder is adhesive capsulitis. Frozen shoulder kind of can be one of 2 things. There's a true frozen shoulder, true adhesive capsulitis. This is a condition that comes out of the blue. People wake up with it. Nothing happened. They were perfect. It can be triggered by different things. Some people think viruses, stress. Something triggers that, and it's a cascade. It's almost an autoimmune reaction in the body, where the body kind of attacks its own shoulder capsule, some of the ligaments that hold the shoulder together, very painful. And that's true frozen shoulder. And that's treated with cortisone injections, physical therapy. 99% of them do not need surgery. But it can take 6 months to thaw out. There's kind of 3 stages to frozen shoulder. That last stage, that thawing phase, can take a long time, 6 months to a year, where people are in physical therapy. The other type of frozen shoulder is kind of related to an injury. For example, someone gets a rotator cuff tear and they're weak, and so they're not moving their arm, and so the months go by, and because they're not moving their arm for whatever reason, an injury or something happens. I've seen it after a stroke. Someone has a stroke and they lose some function in their arm for a little while, and then they recover the function, but now the shoulder doesn't move. This is a frozen shoulder secondary to something else. Frozen shoulder secondary to an injury, and the person didn't move that shoulder for a while, and then it got stiff.
Great, thank you. Also, somebody said, I don't know if you talked about this, how do you diagnose the difference between bursitis and a tear, or what is the difference? Yeah, or how do you diagnose it?
Yeah, very hard for a small tear. A big tear is easy to tell. Bursitis versus small tear, it often comes down to the MRI, if you really want to tell the difference.
Okay, I think you mentioned this about the arm, pain in the shoulder that you feel down towards the elbow. Is that what you were saying before? Or?
Yeah, if it's here, if it's truly, I mean, shoulder pain can radiate all the way down to the mid forearm, and it can still be coming from the shoulder. If it's like that, it's probably coming from the shoulder. If it's really centered around the elbow, then it's something else. But oftentimes shoulder problem, the pain can shoot to the upper arm and even past the elbow to kind of mid forearm. Rarely does shoulder pain come down to the hand and the finger, but I've seen shoulder pain into the mid forearm.
Okay. Could a COVID shot trigger a frozen shoulder? Have you seen that or heard of that?
I have, yeah, I've seen a couple cases. I saw it before from flu shots. So yes, vaccinations can trigger a frozen shoulder.
Okay. For intermittent shoulder pain, is it okay to try either a heating pad or ice? And if so, which one is best?
Yeah, usually I say go with ice for its anti kind of inflammatory properties. The exception is that if it's a sore muscle or a tight muscle, then usually heat. But usually for arthritis pain, itis is bursitis, tendonitis, arthritis, ice. Sore muscle, if you pull the muscle, like pull the neck muscle, pull the back muscle, heat.
Heat. For a shoulder replacement, is the joint weaker, stronger, or the same as far as strength, stability is concerned? That's one. In other words, can an individual continue to train with free weights after a complete recovery period?
Within reason. Yeah, I don't place restrictions. I don't tell someone you can never lift over. I've heard of that. I've heard of surgeons putting a weight limit on it. I don't. I think if you're reasonable, and most people are, not like that guy, that video of that. If you're not doing that, I think you're okay. I wouldn't say it's stronger. No, it's weaker in that you worry a little bit more. Artificial joints can dislocate, parts can come loose. We don't worry about that with our native joint. So if I had to say that, if I had to answer that, I would say it's a little weaker, but I don't put a weight limit on a shoulder replacement. People do go back to the gym. They can lift weights within reason. I mean, I tell people if you can't do 10 reps with that weight or even 15 reps with that weight, maybe it's too much.
And is a shoulder replacement? Okay, hold on. It's hard to hear. In a shoulder replacement, where are the tendons reattached? Could you interested in that procedure? I guess somebody is.
Yeah. So you only detach one to get in to the shoulder. You go between the deltoid and the pec, and you don't need to detach either of them. You come right in between them. One of the 4 rotator cuff tendons has to be detached to get in and do the shoulder replacement. The subscapularis, the one in the front, and it's reattached right back to the bone. So we use sutures, big thick sutures through the tendon, kind of the way we would repair a tendon that had torn traumatically. And so we repaired that tendon at the end of the procedure.
Okay. And you had mentioned the treatment for frozen shoulder would be maybe the injections, and it just takes
Yeah,
time. Is that, yeah,
physical therapy. Physical therapy is
okay.
the mainstay, and sometimes a cortisone injection to give people a head start because sometimes it's just too painful
Mm,
to get going with the physical therapy. But it's the physical therapy, it's the stretching that they
that,
need.
that really does it. And finally, what is the website you mentioned at the start of the lecture? Was there a website that you had up?
I didn't. Maybe you had meant maybe the one you mentioned, the
Oh,
recording.
okay. Oh, that's
Maybe.
that's a question for me. Oh,
I think
yes.
I did mention one. Yeah.
Yeah, the website to uh you see to witness or hear past lectures is www.valleyhealth.com/tune into health, which is one word. Well, thank you so much, Dr. Dasti. This was wonderful. We really appreciate the time you took to